Hello, namaste students. Today we will be discussing about one very important case for both undergraduates and postgraduates from respiratory system. Okay, right. The chief complaint, he complains of breathlessness since 2 weeks, which is aggravated since 4 days. Cough since 2 weeks. These are the two chief complaints. The chief complaints are breathlessness since 2 weeks, which is aggravated since 4 days, and cough since 2 weeks. Coming to the history of presenting complaint, patient complains of breathlessness since 2 weeks, which is aggravated since 4 days. He says breathlessness comes on exertion, and it is aggravated since 4 days. It is insidious onset and it is gradually progressive. There is no issue of PND or orthopnea. So that is the breathlessness elaboration. So it's not acute onset breathlessness, as I have discussed so many times in the previous cases. Breathlessness, if it comes suddenly, you will think of four important causes like acute severe asthma, left ventricular failure with pulmonary edema, a tension pneumothorax, pulmonary embolism, and a foreign body obstruction in a child. Sudden onset of breathlessness. If breathlessness is insidious, slowly progressive, over the years, then if he is a smoker, then you will think of a COPD. Or occupational lung disease like interstitial lung disease. The breathlessness is intermittent, comes and goes, and if it relieves with medication, then you will think of a asthma patient. Asthmatic attacks. Here he says since it is 2 weeks, it is aggravated since 4 days. And another important point in the breathlessness is whether it is cardiac or respiratory breathlessness. So, cardiac breathlessness and respiratory breathlessness, as I have been telling in the last classes, two symptoms you have to ask: orthopnea and PND. If orthopnea and PND is there, that usually goes in favor of the left heart disease, left heart failure. This patient doesn't give history of orthopnea or PND. He doesn't give history of orthopnea and PND. He says the breathlessness, according to him, the grade is MMRC grade 2. Again, I just want to grade the MMRC breathlessness. Grade 0 is breathlessness with a severe exertion. Grade 1 is breathlessness on hurrying on a level ground. Grade 2 is breathlessness when he gets breathlessness when he walks like his peer. So he walks lesser than the speed of his peer. And the grade 3 is breathlessness walking less than 100 yards. And grade 4 on a routine activity. He has a grade 2 MMRC breathlessness. Then whether breathlessness, whether he is on trypopnea, or platypnea, you have to ask. Trypopnea is a feature of pleural effusion. So for example, if he has a right side pleural effusion, if he lies down on the left side, then he will develop the trypopnea. Suppose if you have a left side pleural effusion, if he lies down on the right side, then he will develop the trypopnea. Then platypnea is seen in the AV fistula, pulmonary AV fistula, because of hepatopulmonary syndrome. Then atrial myxoma, valvular thrombus, you will get a platypnea, where the breathlessness on sitting position or standing position. So that point at us is not on any trypopnea or platypnea. And orthopnea and PND history is very important, as I told. That history goes in favor of left heart disease, which this patient doesn't have. Again, to repeat the mechanism of orthopnea and PND, orthopnea, blood from interstitial fluid will go into the intravascular compartment, the pulmonary plethora will occur, and on lying down, the diaphragm will move less, so less vital capacity. PND, same two mechanism, plus during sleep, the respiratory center is less responsive to hypoxia and hypercarbia, and decreased catecholamine support to the LV. There are some standard questions which you should know in your fingertips, students. So that is the elaboration of the breathlessness in him. Then coming to the history of cough, he says there is a history of cough since 2 weeks. This patient says there is a dry cough. It is not productive. So what are the points you ask in the history of cough? Dry or productive? If it is productive, then you will ask some of the important points. Productive, whether then you will ask the quantity. The quantity more than 100 ml is known as a bronchoria, which you get in bronchoalveolar carcinoma, suppurative lung disease like bronchiectasis and lung abscess, necrotizing pneumonia, empyema rupturing into the bronchus with a large amount of sputum production. Then the color of the sputum. The color will give a clue to some diseases. For example, rusty sputum in pneumococcal pneumonia, red currant jelly in Klebsiella pneumonia, pink frothy sputum in pulmonary edema, black sputum in pneumoconiosis, anchovy sauce in ambient liver abscess. These are some of the color which you will ask in the sputum. Our patient no need because he is having a dry cough. He is having a dry cough. Then hemoptysis, whether he is having hemoptysis or not, you will ask in the history of cough. He is not having hemoptysis. Then whether foul smelling. Foul smelling is a feature of bronchiectasis and lung abscess and anaerobic infection. The foul smelling sputum. Okay, then you will ask the consistency. The serous consistency you get in pulmonary edema, pink frothy sputum, bronchoalveolar carcinoma, mucus in a chronic bronchitis and bronchial asthma mucus, and a purulent you get in a bacterial infection, the purulent consistency. These are some of the points which you will ask in the cough, and the duration is very important. Acute 2 weeks, okay, and subacute 2 to 4 weeks, chronic more than 4 weeks. Less than 2 weeks coughs is usually due to upper respiratory tract infection, the infectivity allergy. 2 to 4 weeks, it could be a post-infective reactive airway disease, okay, and even tuberculosis you have to consider whenever the cough is of 2 to 4 weeks duration. More than 4 weeks, especially in a smoker, 2 important conditions you will consider. One is COPD, another is bronchogenic carcinoma. So the duration of cough is important. Our patient has history of cough for 2 weeks. That is history of cough for 2 weeks. Okay. So these are the 2 important symptoms he is giving: a dry cough since 2 weeks, okay, and exertional breathlessness since 2 weeks. There is no history of fever or cold, okay. There is no history of other cardiac symptoms like chest pain, palpitation, syncopal attack, or abdominal pain or swelling of lower limbs. So there is no other symptoms of cardiovascular system symptoms. But one important symptom is the history of weight loss, 3 kg since last 2.5 months. 3 kg history. Last 2.5 months, he says there is a significant weight loss. He is history of body pains and sweating, and as I told, there is no history of leg swelling. There is no history of tightness of chest or no history of wheezing because to rule bronchial asthma, he has breathlessness. Okay, so that's why that history is important. Any chest tightness feeling or a wheezing, you have to ask. There is no history of that. No history of hoarseness of voice, just to rule out endobronchial tuberculosis because he has a 2 weeks history of cough, a chronic cough. That's why that history was asked. So coming to the past history, he is not a hypertensive, diabetic, thyroid, or no previous history of tuberculosis or no previous history of any surgeries. Personal history, he takes a mixed diet, okay, and he is not a smoker and he is not an alcoholic. And his bowel and bladder habits are normal, sleep is normal, and there is no high risk behavior. So these personal history and past history assume importance in tuberculosis, especially because some of these things will reactivate, which are discussed in the case of fibrosis and collapse. There are some factors which will reactivate the pulmonary tuberculosis that goes focus. Which are the factors? Malnutrition, alcohol intake, silicosis, immunosuppressions like diabetes, HIV, pregnancy, postpartum period, chronic hemodialysis, gastric surgery, and gastrointestinal bypass. These are some of the diseases and silicosis which will reactivate the old pulmonary tuberculosis, old Gons focus. So that is why this past history and personal history assumes importance. Okay, so he is not having any significant past or personal history relevant to the present case. Family history, there is nothing significant. There is no contact history of tuberculosis in the family. Okay, right. So this is the history, students. A very simple case. Okay, there are only 2 cardinal symptoms. He has a breathlessness since 2 weeks, probably a respiratory because he is not having orthopnea and PND, and he has a dry cough since 2 weeks, and history of weight loss is there. History of weight loss. So what are the differential diagnoses you can consider? What are the differential diagnoses you can consider? In India, any chronic cough, okay, or subacute cough like him 2 weeks with a history of weight loss, you have to consider a pulmonary tuberculosis. What sort of pulmonary tuberculosis? He has breathlessness also since 2 weeks on exertion. What pathology of tuberculosis can produce breathlessness? A pneumothorax, but a pneumothorax there will be a sudden onset of breathlessness. If a cavity ruptures into the pleura, they will have a sudden onset of breathlessness, which our patient doesn't keep. He has an insidious onset, gradually progressive. So the other pleural disorder, probably a pleural effusion, may be a reason for his breathlessness, is a possibility. So tuberculosis, a pulmonary tuberculosis probably, a pleural effusion is a possibility. And in a pleural disease, they won't have a productive sputum. They'll have only a dry cough. A cough will be there because the irritation of the subpleural lung parenchyma. They'll have only dry cough because parenchyma won't be involved in them. They'll have a dry cough. What are the other DDs you can consider? If you would have been a smoker, a breathlessness and a dry cough is a possibility of emphysema we could have considered. Okay, in the COPD, emphysema, and this is the age to develop COPD around 6th-7th decade. So exertional breathlessness with a dry cough, emphysema variety of COPD we would have considered, but he is not a smoker. Okay, still it is possible, like in alpha-1 antitrypsin deficiency. Okay, another etiology for COPD. That is the second differential diagnosis you can consider. Interstitial lung disease is agriculture worker. Okay, the breathlessness can come insidiously and slowly progressive over the years with a dry cough. Okay, with a dry cough is a possible. Okay, but he has a weight loss. Weight loss history is again as the interstitial lung disease. Okay, they won't have weight loss interstitial lung disease, but he gives history of weight loss. So ILD is another differential diagnosis which you can think of. Okay, right. So then now one more differential diagnosis you can think, because there's a dry cough and breathlessness, is a cardiac, whether he is suffering and he's an old age, 62-year-old. Okay, whether it is just a left heart failure. Okay, but he doesn't give history of orthopnea and PND. He doesn't give history of orthopnea and PND. If he would have had orthopnea and PND, definitely you would have considered a left heart failure as one of the differential diagnoses, because he has exertional breathlessness and a dry cough. Dry cough is one of the criteria for the heart failure. Dry cough is one of the criteria for heart failure. So these are some of the differential diagnoses you can consider. Let us see with the examination probably what he is suffering from. So let us go to the examination. Okay, I'll make him sit. Okay, students, general physical examination, what you will look top to bottom in respiratory system. Okay, first I will look for pallor. There is no pallor, massive hemoptysis and extensive sputum production can produce anemia in a respiratory system disease. Let us look for icterus. There is no icterus. Some of the causes of icterus in respiratory system is pulmonary infarction, red deposition of pneumococcal pneumonia, then the drug adverse reaction, antitubercular drug adverse reaction, then lymph nodes either due to the carcinoma or tuberculosis can press on the biliary radicals, can produce icterus. There is no icterus. Let me look for cyanosis. There is no cyanosis. The rapidity of the respiratory disease will determine the cyanosis. For example, if extensive pneumonia, a chronic bronchitis, a tension pneumothorax, acute severe asthma, all can have a central cyanosis. There is no cyanosis in it. Okay, clubbing. So clubbing. So students, there is no clubbing. It's not having clubbing. Okay, clubbing. You should know some of the important cause of clubbing in respiratory system disease. Which are those diseases? Suppurative lung disease like bronchiectasis, lung abscess, interstitial lung diseases can have clubbing, mesothelioma, bronchogenic carcinoma. Some of the important causes of clubbing in respiratory system disease. Okay, is not having pedal edema. Pedal edema is not there. Okay, then I'll just look for the lymph nodes. Okay, right. Lymph nodes, students, two lymph nodes are important, as I told in the last class, the supraclavicular lymph nodes, okay, and scalene lymph nodes, and posterior cervical group of lymph nodes. These lymph nodes are important. Let me look for a scalene lymph node. You have to insinuate your finger to the medial end of the clavicle. Ask him to shrug the shoulder. Email ಮಾಡ್ಕೊಳ್ಳಿ ಎರಡು ಕಡೆ. You have to insinuate your finger here for a scalene lymph node. ಸಾಕು. Then you have to look for a supraclavicular lymph node. The whole of the right lung and the left lower lobe drains into the right supraclavicular node. Okay, and the left upper lobe drains into the left supraclavicular lymph nodes, and posterior cervical group of lymph nodes, especially in this case because you are suspecting tuberculosis. Posterior cervical lymph nodes. It's not enlarged. Okay. Then what are the other things you look top to bottom in a respiratory system examination? In the eyes, what are the things you look? For example, if there is a ptosis, a pancreas tumor can produce a Horner syndrome. Okay, a ptosis is a feature along triad with the rib erosion, so the pain and a small muscle wasting that can develop in a pancreas. So ptosis, conjunctival congestion in a superior vena cava syndrome and COPD patients, you can have a conjunctival congestion. Flictular conjunctivitis in a primary tuberculosis, choroid tubercles in a miliary tuberculosis, and you can get a retrovalvular neuritis in ethambutol toxicity, okay, and papilledema in COPD patients. So there are some of the things which you have to look in the eye in respiratory system examination. Okay, in our patient, the eye examination is normal, and because we are thinking tuberculosis in this patient, the tubercular markers, okay, external markers of tuberculosis you have to look, which are the flictular conjunctivitis in the eye, the lupus vulgaris, a skin manifestation, scrophulodema, okay, atypical tuberculosis, okay, scrophulodema, then erythema nodosum in the leg, and tinea versicolor, even epididymoarthritis. These are some of the external markers of tuberculosis which you have to look. Then any halitosis there you have to look, and then any flapping tremors is there you have to look. Okay, let me check for the flapping tremor. He has a essential senile tremor, students. See, the tremor is there. It's not a flapping tremor. It is a senile tremor he is having. This is a senile tremor what he is having. This is not a flapping tremor. It flaps like this. Okay, flaps like this. This is a senile tremor which is having. So these are the things which you look in top to bottom in respiratory system examination. So the vitals, coming to the vitals, BP is 130/70, right arm supine position, and temperature is afebrile, pulse rate 78 beats per minute, there is no rise of JVP, SpO2 is 94%, okay, with the room air oxygen. This is the general physical examination what you look. Okay, now come to the respiratory system examination. First we'll do the inspection and then we'll go for the palpation. What are the things you look in inspection? Okay, upper respiratory tract examination. The nose, you have to look for any deviated nasal septum or any polyp is there. Let me check for that. There is no DNAs or no polyps. Polyps you get in aspirin-induced asthma, vaginal granulomatosis, allergic bronchopulmonary aspergillosis. Then the oral cavity. Okay, there is no nicotine staining because he is not a smoker, and oral hygiene appears to be good. Okay, oral hygiene is important especially in lung abscess patients because they develop lung abscess because of the aspiration of the microorganisms from the oral cavity. Okay, then the upper respiratory tract extends till cricothyroid. Okay, below that is the lower respiratory tract. Let me examine the lower respiratory tract inspection. Okay, what are the things you look in inspection? Patient should be made to sit like this. Ideally, the respiratory system examination is better in standing position, but for our convenient purpose, we will make them sit and we will examine them. So let us examine the lower respiratory tract inspection. You should look for any drooping of the shoulder. There is no drooping of shoulder, both the sides. Then the tracheal position. The tracheal position, students, here it appears central. There is no trial sign. Trial sign means here the clavicular head will become prominent, okay, but there is no clavicular head prominent, okay. Then supraclavicular, right side there is a slight hallowness, supraclavicular hallowness is present, okay. Then pectus excavatum and carinatum. There is no pectus excavatum, there is no pectus carinatum, okay. And even is not having any kyphosis or scoliosis. Kyphosis and scoliosis is not present. And the inspection, you have to look whether he is using any axillary muscles of respiration. Which are the axillary muscles of inspiration which you will look? Scalene muscles, sternocleidomastoid, trapezius, okay, and pectoralis, which is not using it. Axillary muscles of expiration, the latissimus dorsi, abdominalis, which is not using it. Okay. So these are the inspectory findings which you will look. So the tracheal position, the shape of the chest, drooping of shoulder, kyphosis, scoliosis, pectus excavatum, carinatum, okay, axillary muscles of respiration whether he is using. And then you look for any dilated veins or scars are present or not. And the apical impulse, the one thing important is apical impulse. Apical impulse in an inspection, it appears to be the fifth intercostal space. You have to make him lie down, look tangentially or look from the foot end. Okay, I will make him lie down and I will see for the apical impulse. Okay, right. You have to look for the apical impulse tangentially. You have to look. Okay, that is one method. Another is you have to go from the foot end, then you have to examine for the apical impulse. Here it is in the fifth intercostal space only, apical impulse. Okay, right. Students, its respiratory rate is 20 cycles beats per minute. Okay, it is at the upper range of normal. Okay, which upper range of normal. So that is one thing which we have to tell in the vitals. Okay, which I forgot to tell. Okay, right. So these are the things which you look in the inspection. Okay, inspection we have not got any positive findings. Okay, we have not got any positive findings inspection. Let us go to the palpation. So palpation, tracheal position and other things we will be checking one by one. First you have to look for a tracheal position. Tracheal position, students, 3 fingers method. The 3 fingers you will come from above downwards. Put your finger in between trachea and sternocleidomastoid masthead. Okay, trachea is central. It is not deviated. Okay. Then you have to feel for the apex beat. Okay, you have to make him lie down, and the apex beat here it is in the 5th intercostal space, just medial to the midclavicular line. Then tracheal tug you have to see. Let me go back and check for the tracheal tug. You have to just with the fingers you have to hold. Okay, and you will feel a downward tug if there is aortic aneurysm. There is no tracheal tug. There is no tracheal tug. Then here to take the measurements, students. The measurements I have taken. The AP diameter is 18 centimeter. The transverse diameter is 26 centimeters. Chest circumference 81 centimeters. Chest expansion is 2 centimeters. Chest expansion is reduced. Make a point. Chest expansion is reduced. Hemithorax, right side is 42 and left side is 41. Right side there are slight bulges there. Okay, compared to left side. Okay, right. So next, the other things, the movements of the chest, you have to look, okay, movement of the chest and vocal fremitus, intercostal tenderness, friction fremitus, tactile fremitus, okay, you have to look it. Let us examine one by one. Let me look for the respiratory movements first. For the apical part, respiratory movements, you have to go backwards. Students, my hands are moving both right and left side, okay, but I feel there is decreased movement both right side and left side for the apical part. Let me examine for the anterior part. For the anterior part, you can take a fold of skin. Who's ready? It is expanding bilaterally, but slightly less. Even while taking the measurement also, you could make out student only 2 centimeter expansion is there, but bilaterally it is reduced, okay, anteriorly. For a posteriorly, for a posterior movement, let us check. Take a fold of skin. This is one method. Study. It is expanding equally on both the sides, but it is reduced. Okay, the chest movements. Next, you have to look for vocal fremitus. Vocal fremitus, let me check and let me tell the findings. Okay, right. Okay, let me check the vocal fremitus on all the areas. ಹೇಳಿ
ಒಂದು 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 ಒಂದು
ಹಿಂಗೆ ಇಟ್ಕೊಳ್ಳಿ ಕೈ ಹೇಳಿ
ಒಂದು 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 ಒಂದು
ಆ ಸೈಡ್ ತಿರ್ಕೊಳ್ಳಿ ಕೂತ್ಕೊಳ್ಳಿ ಆರಾಮಾಗಿ ಕೂತ್ಕೊಳ್ಳಿ ಹೇಳಿ
ಒಂದು 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 ಒಂದು
vocal fremitus, it is normal on right suprascapular, right clavicular, right mammary region. It is reduced in the right axillary, infraaxillary, right interscapular, infrascapular. So right suprascapular, right supraclavicular, right infraclavicular mammary, it is normal. Right axillary, infraaxillary, right interscapular, infrascapular, it is reduced. The same thing on the left side, left suprascapular, left infraclavicular, mammary, it is normal. Left axillary, infraaxillary, it is reduced. Left suprascapular, it is normal. Left interscapular and infrascapular, it is reduced. Vocal fremitus. Then I have to look for intercostal tenderness. Okay, let me check that. And any friction fremitus and tactile fremitus. No intercostal tenderness, just to rule out empyema. Then you palpate for the friction parameters which you get in pleural rub. Tactile parameters is a palpable rhonchi or a rail. Rhonchi is better palpated than rails. Then rib crowding also you can look with both the fingers like this. Then any subcutaneous emphysema is there, you can see by palpation. These are the things which you look in palpation. So what are the positive findings you got? There is a decreased movement bilaterally, both right and left side. Okay. VF is reduced both right side and left side backwards, interscapular and infrascapular, and also in the axillary area. VF is reduced. Which are the condition VF will be reduced? Pneumothorax and pleural effusion. So let us keep this now. And the dictymid respiratory system is whichever side there is a reduced movement, pathology is on that side. But here there is a reduced movement on both the sides. Expansion is only 2 centimeters. Now let us go to the percussion. Percussion, suprascapular chronic isthmus percussion. You have to percuss from backwards. Okay. Chronic isthmus is a band of resonance bounded medially by the sternocleidomastoid, laterally by the acromion, posteriorly by the trapezius, anteriorly by the clavicle. Resonant. Resonant. So chronic isthmus is normal. Let me percuss anteriorly. Direct clavicular percussion. Resonant. Infraclavicular resonant. Resonant. Mammary. Resonant. Let me percuss the right side axillary. I am not getting any resonant sound. It is dull. Even axillary, infra-axillary. Let me percuss that side. Yeah, let me percuss left side. Here also axillary, infra-axillary dull note. Okay. Ang turn ಮಾಡ್ಕೊಂಬಿಟ್ಟು ಹೀಗೆ. ಹಿಂಗೆ ಇಟ್ಕೊಳ್ಳಿ ಶೆಟ್ಟಿ ಅವರೇ, ಹೀಗೆ ಹಿಂಗೆ ಹಂಗಲ್ಲ. ಹಾಗೆ. Let me percuss back side. Suprascapula. Resonant. Interscapular. It is dull bilaterally interscapular. I am getting pain, stony dullness. Infrascapular, bilaterally, no sound. Then you have to percuss in the percussion, tidal percussion and trops area percussion. Let me do the tidal percussion. Percuss the liver dullness. This is the second rib. Resonant, second space. Third space resonant. Fourth space resonant. So fifth space is the dullness. Okay. Usuru tagoli. Hage itkoli. Now it is resonant. Okay. So tidal percussion. So the diaphragm is moving normally. It is moving normally. Now the trops area percussion. Let us do now. Okay. Trops area. Let me percuss. Malkoli shettivar. Okay. Because he has a dull node posteriorly, interscapular and infrascapular, I have to do a tidal percussion backwards. Let me see tidal percussion on the back side. Resonant, dull. So the upper level of dullness in the mid-scapular line I will take. Okay, ask him to take a deep respiration. Okay, usuru tagoli. Hage itkoli. Usuru tagoni idkobeku. Usuru tagoni idkoli. It still remain dull. It still remain dull. So the students, the dullness, whatever you are getting is not moving and it is not becoming resonant. That means it is supradiaphragmatic pathology. Whatever we are dealing here, the supradiaphragmatic pathology. If the dullness was due to infradiaphragmatic pathology like a liver abscess, okay, or a subdiaphragmatic abscess, the dullness would have been moved down, okay, and it would have become resonant and taking a deep inspiration. But here it is dullness remains. So it is a supradiaphragmatic pathology producing the dullness. Okay, right. Let me focus the trops area percussion. Trops area boundaries I will tell students. Okay, Harrison boundaries, what they say, upper by the sixth rib. Okay, sixth rib. Let me count. Second, third, fourth, fifth, sixth. Sixth rib. Sixth rib above, costal margin below, mid-axillary line laterally. This is a semilunar space. Sixth rib above, costal margin below, mid-axillary line laterally. The other clinical books gives the boundaries as the right side by the left lobe of liver, left side by the spleen, above by the lung resonance, below by the costal margin. Now let me focus the trops area here. Okay, so this is the trops area, 6th rib, costal margin and mid-axillary line. Let me focus it. It is dull to percuss. It is dull to percuss, but here see, resonant. Third space, the trops area is dull to percuss. So what are the positive findings you got, students, on percussion? You have a stony dullness in the right upper and lower interscapular, infrascapular. Left side also interscapular, infrascapular stony dullness. Right axillary and infraaxillary stony dullness. Left axillary, infraaxillary stony dullness. Trops area is dull to percuss, and tidal percussion on the right side which we did is the dullness is not moving down. So it is supradiaphragmatic dullness, not an infradiaphragmatic dullness. Okay. This is the percussion findings what we got. Okay. Now let us go to the auscultation. I'll auscultate all the areas. Okay. And then let us see what findings he has. Students, there is reduced breath sounds. Okay, reduced breath sounds on the right upper interscapular, infrascapular, axillary and infraaxillary area. Same thing, left side, the axillary, infraaxillary, left upper interscapular, infrascapular, there is absent breath sounds. Both right side and left side, there is absent breath sounds. The other areas, normal vesicular breath sounds is heard. Let me check the vocal resonance. Ready? Ittag matra.
ಒಂದು 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 ಒಂದು
ಹಂಗೆ ಟರ್ನ್ ಮಾಡ್ಕೊಳ್ಳಿ. ಹಂಗೆ ಹಂಗೆ ಈ ಸೈಡ್ ಹಾಂ.
ಒಂದು 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 ಒಂದು
ಯಾ ಹಿಂಗೆ ಟರ್ನ್ ಹಿಂಗೆ ಟರ್ನ್ ಮಾಡಿ. Yeah, students, vocal resonance, whichever areas vocal fragmentus is reduced, for here in this case, upper interscapular, lower interscapular, infrascapular, axillary and infraaxillary, on the right side, vocal resonance is reduced. Vocal resonance on the left side, okay, axillary, infraaxillary, then interscapular, infrascapular, it is reduced. But the other areas, vocal resonance is normal. VF and VR are corollaries. Wherever VF is reduced, VR also will be reduced. Both will go together and you can use it as a verification. You can use that as a verification. There are no other added sounds. Okay, there is no rhonchi, there is no crepitations are heard anywhere. Okay, and here in this case, especially because there is a stony dullness and the interscapular and infrascapular, then above the level of the dullness, whether you get a resonant note, a boxy resonant note I have to see in percussion. Okay, that is known as cardiac resonance in pleural effusion because of the relaxed lung above the pleural effusion. Relaxed lung above the pleural effusion, cardiac resonance is there or not, you have to check. That is one thing. And some patients above the level of pleural effusion, you may get a bronchial breathing, a tubular bronchial breathing. this patient is not having. So those two things you have to check. That is important, students. This patient is not having a bronchial breathing above the level of pleural effusion and a cardiac resonance because of the relaxed lung. So coming to the other systems, CVS S1 S2 is heard and it is normal. Per abdomen it is soft, non-tender, and CNS it is normal. No positive findings got. Okay, right. Now let us come to the analysis of the finding. So students, at the end of history, what are the differential diagnosis we thought? Okay. Now what are the positive findings we got in him? Okay. And like we'll analyze the patient. What are the positive findings we got in this patient? Inspection, there was no significant findings. We couldn't get any significant finding. Palpation, there was a reduced movement both the sides. There was reduced movement both the sides. Palpation. Okay, that is a positive finding which you got. And vocal fremitus was reduced both on right side and left side, axillary, infraaxillary, upper interscapular, infrascapular area. Percussion, we got a stony dullness on the right interscapular, infrascapular, axillary, infraaxillary. Left side also interscapular, infrascapular, axillary, infraaxillary. We got a stony dullness. And tidal percussion show that the dullness was due to supradiaphragmatic pathology, not infradiaphragmatic pathology. Then on auscultation, you got absent breath sounds on the right interscapular, infrascapular, axillary, infraaxillary. Left side interscapular, infrascapular, axillary, infraaxillary. And vocal resonance is reduced on the same areas. Okay, axillary, infraaxillary, interscapular, infrascapular, right side. Left side axillary, infraaxillary, upper interscapular, infrascapular, absent breath sounds. Okay, students, right. So all the features, okay, clinical features are favoring into a pleural effusion, a very interesting bilateral, both right and left side. That is the reason probably trachea is not shifted, neither to right side nor to the left side, because of the bilateral pleural effusion. Or else trachea should have been shifted with the effusion of around 1500 ml. That is a quantity which you required for a tracheal shift, but here it is not shifted. What are the other DDs you thought at the end of the history? You thought of a left ventricular failure, but on clinical examination, cardia is normal. There is no other findings, and you got all the respiratory findings in him, which is favoring pleural effusion, which you thought at the end of history also because of the exertion of breathlessness, dry cough. Because pleural pathology will produce a dry cough, a parenchymal pathology will produce a productive cough. Okay, you thought of a left ventricular failure, COPD you thought, but there is absent breath sounds here and stony dullness. COPD you will get a hyperresonant note. You will get a hyperresonant note in a COPD, but here hyperresonant note is not there. No rhonchi, no crepitation, which you get in COPD or emphysema. So that is not a possibility. ILD, you will get a fine inspiratory crepitation, which is not present in this case. Okay, so ILD is another DD you thought of. COPD, ILD, heart failure, the other DDs which you thought in this case. So all the three are not possible, are highly unlikely after the end of the clinical examination. So it's a nice case of bilateral pleural effusion. So what could be the pathology in this case? Because weight loss history is there, okay, and there is a 2 weeks history, and he's not a smoker. If you would have been a smoker, okay, first I would have thought of a malignancy with the weight loss history and bilateral pleural effusion. But here there is no history of smoking. So I want to put tuberculosis as the first etiology for the pleural effusion. Next probably could be a malignancy, the second etiology for the pleural effusion. Then how do you proceed? The basic investigation, what you will do is a chest x-ray, and in chest x-ray showed bilateral pleural effusion, which I will show in the x-ray view box. A classic bilateral pleural effusion, a very interesting case of bilateral pleural effusion. That is why mediastinum is not shifted, students take a central leaning. Okay, right. So dear students, so this is the x-ray of the patient which we have discussed. Okay, so let us carefully study the x-ray. This is a PA view of the patient. Okay, because you can see two ribs are above the clavicle. Okay, you see here there is a homogeneous opacity on the right lung field, also on the left lung field, a homogeneous opacity. The trachea, students, see this is a trachea, it is central only, this is the left division of the trachea. Trachea divides into two branches. See this trachea is central only, it is not shifted. So even though there is a homogeneous opacity on the right side here, and which is having a shape. You can see here the L is S shape. Okay, the highest point is in the axilla. Highest point is in the axilla. This is the L is S shape curve. Probably because the two schools of thought. One is a capillary suction is the reason for the L is S shape curve. But some say it's a radiological illusion. Okay, the radiological illusion, that is the reason for the L is S shape curve. So here you see the angle, two angle you have to see. One is here a costophrenic angle which is obliterated. Here you cannot make out the costophrenic angle, and this is a cardiophrenic angle. This is a cardiophrenic angle. This is a costophrenic angle. So costophrenic angle is obliterated. Okay, and there is a S-shaped curve, and there is a homogeneous opacity. And here also left side you can see, students, the costophrenic angle is obliterated. Okay, obliterated. And here also the pleural fluid is above here. Okay, you can see the upper part is here. Here also it is in the process of becoming attaining a L is S-shaped curve. And here also left side the costophrenic angle is obliterated. But right side is more compared to the left side. So right side, even though there is a pleural effusion so much, the trachea should have been shifted to left side. Why it is not shifted? Because here left is also there is a pleural effusion. That is why mediastinum is not shifted. Trachea is central. That is why clinically also we got the trachea was central only. It was not shifted. To obliterate the angle in a pleural effusion, you need minimum of 300 ml of the fluid. And to shift the mediastinum to the opposite side, you require 1500 ml of fluid. In a case of pleural effusion, if mediastinum is not shifted, then you have to think like this: the bilateral pleural effusion or a pleural effusion associated with a collapse, or in a mesothelioma with a pleural effusion, mediastinum won't be shifted. Okay, mediastinum won't be shifted, students. And then I discussed the bilateral cause of pleural effusion. With cardiomegaly, it is heart failure. Without cardiomegaly, it could be a hypoalbuminemia, pulmonary infarction, malignancy, and in India, tuberculosis you have to confirm. And he is suffering from tuberculosis. His ADA was elevated. Cell count was showing a high lymphocytes. Okay, so a very nice case of bilateral pleural effusion. And then the tapping, one point I want to tell, you should not tap more than 1 liter of thoracocentesis, because that will produce a re-expansion pulmonary edema. So while tapping, you should be careful. You should not tap more than 1 liter fluid. And one more is, as I told, the interfissure fluid collection may be there. Okay, a phantom tumor. Okay, you should know about the phantom tumor. And one more point in the radiology is subpulmonic effusion. Subpulmonic effusion is there won't be any obliteration of the angle of the costophrenic angle, but just there will be elevation of the diaphragm. That is known as subpulmonic effusion. And subpulmonic effusion can be confirmed by a decubitus X-ray. Lateral decubitus X-ray, if you take, the fluid will become settled down to the down. Then you can make out the fluid there. It will separate from the parietal pleura, from the rib cage. You can make out the fluid. So if you take a lateral decubitus X-ray, subpulmonic effusion can be confirmed. Okay. This is the X-ray picture of this patient. A very nice case of a bilateral pleural effusion. Very interesting case. Thank you. Then analysis should be done. A pleural fluid analysis was done. AD was showing around 70 international units, which is favoring the tuberculosis. And lymphocyte predominant was there. Protein was elevated and the Light's criteria was fitting in. Okay, so it was an exudative pleural effusion with lymphocyte with ADA elevation, and diagnosis confirmed it is tubercular pleural effusion. And the specimen which was drawn for a diagnostic aspiration was also straw color. Okay, so it's a nice case of tubercular bilateral pleural effusion. Okay, a very interesting case. Okay, usually we get most of the times we get unilateral pleural effusion. Very lucky to have a bilateral pleural effusion with no mediastinal shift, which is a very rarity. So let me discuss about the detail about the pleural effusion. Okay, so the pathophysiology of the pleural effusion. The pleural effusion is formed. You have a visceral pleura and a parietal pleura. It can be formed by the fluid which is secreted by the capillaries in the parietal pleura. Okay, or it can be produced from the parenchymal interstitial fluid which will seep from the visceral pleura into the pleural space, or it can be produced by the fluid in the abdomen through a small holes in the diaphragm. These are three mechanisms. A parietal capillaries can produce it, or from the parenchyma, the interstitial fluid can seep into the pleural space, or from the abdomen through the small holes in the diaphragm, it can seep through. And the lymphatics in the parietal pleura will absorb the pleural fluid. The lymphatic absorption is 20 times having more capacity than the formation of the pleural fluid. The lymphatic capacity is having a 20 times more capacity than formation of the pleural fluid. So, pleural effusion is formed any condition which will increase the formation or any condition which will decrease the absorption. Pleural effusion can be produced by any condition which will increase the formation by 3 mechanisms which I told, or any condition which will decrease the absorption through the lymphatics. Okay. Now, how do you diagnostically approach a pleural effusion? So, till now, ideal was the chest X-ray, but now of late ultrasound has taken over the chest X-ray because it will guide you to exact place where you can do a thoracocentesis. Then you have to establish whether it is an exudate or transudate. Usually, a transudate cause is due to the alteration in the systemic causes. Systemic causes which will alter the formation of pleural fluid formation, whereas exudate cause will be a local cause which will alter the formation of pleural fluid. The common cause of a transudate pleural effusion is heart failure or cirrhosis. A common cause of exudate pleural effusion, okay, especially in India, I'll put first as tuberculosis. The Western books, the Harrison says, the common cause of exudate pleural effusion is pneumonia, parapneumonic effusion, malignancy, viral pneumonia, and pulmonary embolism. Okay, so first you have to establish whether it is exudate or a transudate. How do you establish exudate or transudate? Okay, Light's criteria, very important criteria you have to remember. Light's criteria is pleural fluid protein divided by the serum protein should be more than 0.5. Pleural fluid LDH by serum LDH should be more than 0.6, or the pleural fluid LDH should be more than 2/3 of the serum LDH. Out of these three, if any one is there, then that is the Light's criteria. If you use the Light's criteria, 25% of the pleural effusion will come transudate pleural effusion you misdiagnose as exudate pleural effusion. So whenever you have a doubt, at that time you have to do a serum protein minus pleural protein. If it is more than 3.1 grams per liter, then you can take it as a transudate, not an exudate. So this is the first basic approach, whether it is a transudate or exudate. Then how do you further proceed, okay, with the diagnostic approach? So first you say whether transudate or exudate. If it is a transudate, the three most important causes for a transudate pleural effusion: heart failure, liver problem like cirrhosis, or renal problems, nephrotic syndrome, CKD, AKI. These are three important causes of transudate pleural effusion. If it is an exudate, then blood glucose level you have to see. If blood glucose is less than 60, then you will consider rheumatoid arthritis, malignancy, or bacterial infections. If glucose is less than 60. If glucose is not less than 60, then you do the protein analysis, cell type, differential count, gram stain, and culture of the pleural fluid. With this much, most of the times you will come to a diagnosis. If still diagnosis is not possible, one thing which you have to always remember is, in an undiagnosed case of pleural effusion, is pulmonary embolism. Then you have to work out for a pulmonary embolism. How do you work out for pulmonary embolism? You will do CT angio, ventilation perfusion scan if contraindications to CT pulmonary angio. So if pulmonary embolism is diagnosed, treat it. If no pulmonary embolism, then you have to send for markers for tuberculosis. This is what the Harrison says. But in India, first only you have to send for pulmonary tuberculosis markers like ADA, smear for AFB, and a culture of the pleural fluid for AFB, or a biopsy of the pleural biopsy with the CT or ultrasound guided pleural biopsy. So if tuberculosis is confirmed, treat for tuberculosis. If still diagnosis is not established, then if pleural effusion is resolving, don't be aggressive in evaluating, just observe the patient. Or else you can do thoracoscopy, ultrasound or CT guided pleural biopsy to establish the diagnosis in the last stage. This is how you approach a case of tuberculosis. But in our patient, we did even straw color, lymphocyte was there, ADA was elevated. It was a classic case of bilateral pleural tuberculosis. Now let us come to the each and every cause of pleural effusion. First, let us consider the two important most cause of transitive pleural effusion, left heart failure. Left heart failure will produce a pleural effusion which is a transitive. Usually, a biventricular failure will produce a pleural effusion because the pulmonary circulation drains both into systemic as well as the pulmonary circulation. A pleural effusion due to heart failure is usually bilateral. If unilateral, usually it occurs on the right side. If it is unilateral, if there is a fever and if there is a chest pain, then only you have to tap in a heart failure to diagnose a pleural effusion, any other thing apart from transit. Or else in a heart failure with pleural effusion, no need to tap. A chest pain, a fever or unilateral, then only you have to tap it. A pleural fluid NT-proBNP, if it is more than 1500 nanograms per ml, it is highly suggestive as heart failure as a cause of pleural effusion. Okay. So the next cause of transitive pleural effusion is cirrhosis of liver. 5% of the cirrhosis of the liver will develop pleural effusion, and again here it is a transitive pleural effusion and it occurs right side. Sometimes the accumulation of fluid is so much on the right side of pleural effusion, the patient may develop symptomatically breathless. So these are the two important causes of transitive pleural effusion. Now let us go to the exudative cause of pleural effusion. The one is pneumonic or parapneumonic effusion. Lung abscess, pneumonia, bronchiectasis. These three things can produce a parapneumonic effusion. It is exudative. If it is an aerobic organism, usually it will be acute history. They will have a productive sputum production, chest pain, fever, and leukocytosis. If it is an anaerobic organism, it is a subacute onset. Weight loss will be there, anemia, and a history of aspiration and a brisk leukocytosis. Pleural fluid can be diagnosed by a lateral decubitus X-ray, HSCT or ultrasound scan. If the distance between the pleura and the parenchyma is more than 10 mm, then you have to put a needle to aspirate the fluid. If the distance between the pleura and the parenchyma is more than 10 mm, you have to aspirate the fluid for a diagnosis. You have to do a thoracotube thoracostomy, okay, to treat the patient if they don't respond to therapeutic thoracocentesis. If still they don't respond to tube thoracostomy, then you have to put a tissue plasminogen activator 10 milligram. If streptokinase is available, you can put it. Or deoxyribonucleic acid, deoxyribonuclease 5 mg. That will dissolve the adhesions and helps in drainage of the pus. If still not responded, you will do a thoracoscopy and the adhesion should be prevented. And if still not responded to thoracoscopy and adhesions not able to clear it, then you do a decortication where a peel of that pus will be removed from the peripheral. So a treatment more than thoracocentesis, is required in the increasing order of frequency in the following situations. Which are those situations? Loculated pleural effusion, yes, you need more than thoracocentesis. pH less than 7.2. Yes, it is still more important than lacunar diffusion. See, the pleural fluid glucose less than 60. Yes, you need still more than thoracendosis, and it is more than the pH less than 7.2. Gram stain positivity in the pleural fluid, you need more than thoracendosis, and it has high importance than the glucose. And gross pus when tapping, yes, you need more than thoracendosis, and that importance is more than the gram stain. So, in the increasing order of frequency, this is how the treatment requires in a pneumonic effusion. This is a very important cause of exudative pleural effusion. Next is malignancy. 70% of the malignant pleural effusion is due to CLN, breast, and lymphoma. It's the exudative pleural effusion, and paracentesis can establish the cytology of malignant cells. A involving catheter or a thoracostomy can release the symptoms, and usually the symptomatic treatment will be given because it's already a stage 4 once pleura is involved. They'll have dyspnea on exertion, and you can do a pleural abrasion, or you can inject a doxycycline 500 mg to do pleurodesis. Mesothelioma. Usually a history of asbestos exposure will be there. They'll have a chest pain, a dyspnea with a pleural effusion, and a pleural thickening will be there. Diagnosis can be established with thoracoscopy and biopsy of the pleura. That is mesothelioma. Then you have the next important cause of exudative pleural effusion, pulmonary embolism. One of the least importance given to pleural effusion by all the clinicians. Any undiagnosed pleural effusion, you have to always keep in mind the pulmonary embolism. You have to keep in mind pulmonary embolism, one of the important cause of exudative pleural effusion in an undiagnosed case. It is almost always exudative, the pulmonary embolism pleural effusion. And the treatment for pulmonary embolism pleural effusion is same like without pleural effusion. So you have to anticoagulate. If there is any increase in the pleural effusion after anticoagulation, then you have to consider three things: either hematite developed hemothorax, or a recurrent pulmonary embolism, or infection has occurred. So these three things you have to keep in mind after starting anticoagulation if there is a worsening of the pleural effusion. In India, these three things gives heroism first, but in India, first and foremost, I want to consider for exudative pleural effusion tuberculosis. The mechanism of tubercular pleural effusion is because of the hypersensitivity reaction to the tubercular bacilli. It is the exudative pleural effusion, and lymphocyte predominance will be there when you tap it. ADA more than 40 will give a clue to tubercular etiology, and more than 70 is highly suggestive of tuberculosis. Gamma interferon will be 140 picograms per ml. And tubercular pleural effusion, apart from cytology, can be established by smear examination, a culture, and a pleural biopsy can be taken. It will establish the diagnosis of tubercular pleural effusion. The treatment of tubercular pleural effusion is same like a pulmonary tuberculosis. Next is chylothorax. Chylothorax will occur because of damage to the chylous duct, a thoracic lymphatic duct. Usually they will have a massive pleural effusion. The causes of chylothorax are a trauma, tumor, tuberculosis, yellow nail syndrome. Yellow nail syndrome, as I told in bronchiectasis, it's a lymphatic obstruction problem where they will have pleural effusion, bronchiectasis, and yellow nails and lymphademomas. So, yellow nail syndrome, absence of thoracic duct, lymphangioliomyomatosis, filariasis. Some of the cause of chylothorax. You have to distinguish in the chylothorax whether it is a chylous or pseudochylous. How do you distinguish a chylous from a pseudochylous? If you add ethyl ether, the triglycerides which is present in a chylous will disappear, but not in a pseudochylous. For a chylothorax, you can diagnose by putting a Sudan 3 into a butter, ask the patient to eat it, or a radioiodine with triglycerides, you can ask the patient to eat it. Then it will appear in the pleural. If trauma is excluded, you can do lymphangiogram and mediastinal CD to establish the chylothorax etiology. The most common thoracic surgery will produce the chylothorax. The treatment for chylothorax is thoracostomy, but thoracostomy tube should not be put for a longer period because that will produce immunodeficiency and malnutrition. Actiniotide can be given. A pleuroperitoneal shunt can be done for a chylothorax. A pleuroperitoneal shunt. If not responded to these three things, then you have to a blockage, or a ligation, or the thoracic duct you have to do it. A non-callous pleural effusion and a smear will show only cholesterol crystals and a negative Sudan test, the negative radioiodine test, and a proper history will say this is a pseudocalus. Next is hemothorax. If the pleural fluid hematocrit is more than 50% of the blood hematocrit, then hemothorax is confirmed. It could be due to a commonest cause is trauma. It could be due to a rupture of the pleural blood vessel or a tumor. If the rate of blood loss is 200 ml per hour, then you have to do a coil embolization of the artery or thoracotomy and thoracoscopy. If the pleural blood vessel is the cause, then you have to approximate both the pleurals. This is about hemothorax. So, what are the other miscellaneous causes of the pleural effusion? Esophageal rupture, pancreatic disease can produce a pleural effusion with a raised amylase level. Asbestosis is a diagnosis of exclusion, one of the causes of pleural effusion. And if pleural fluid has a neutrophils but no pneumonia, then you have to think subdiaphragmatic abscess as the cause of pleural effusion. Drugs will usually produce the eosinophilic cells as a cause of pleural effusion. Then Meeks syndrome and ovarian hyperstimulation syndrome can produce a right-sided pleural effusion. The other causes: radiation therapy, abdominal surgeries, liver transplantation, lung transplantation, cardiac transplantation, and alveolar insertions, central lines. All these can produce a pleural effusion. So, let us enumerate the causes of transudative and exudative pleural effusion in total. So, the cause of transudative pleural effusion, the three things first: heart failure, liver disorders, renal failure. Then you have myxedema, a transudative pleural effusion, urinothorax, then peritoneal dialysis, supravenacal obstruction. These are the transudative causes. I repeat, the three cardinal causes: myxedema, urinothorax, peritoneal dialysis, supravenacal obstruction. The exudative causes: malignancy, either a primary or mesothelioma or metastasis; infection, a bacterial, viral, tuberculosis, fungal, parasitic infections. Connective tissue diseases, rheumatoid arthritis. Rheumatoid arthritis will have a glucose level less than 60. SLE, drug-induced SLE, Sjogren's syndrome, Wegener's granulomatosis, Church-Stewart syndrome. Connective tissue diseases. Pulmonary embolism, abdominal causes: cirrhosis, subdiaphragmatic abscess, liver transplantation, esophageal variceal band ligation, sclerotherapy, pancreatic disease, esophageal ruptures. This is the abdominal cause of pleural effusion. Asbestosis, sarcoidosis, uremia, Meek syndrome, ovarian hyperstimulation syndrome. These are all causes of again exudative pleural effusion. Then you have a CABG, post CABG pleural effusion. Post CABG, within the 1 week you may get a pleural effusion, especially on the left side, which may have eosinophils. But after 1 week, if you develop the pleural effusion after CABG, it will have the lymphocytes and be recurrent. So post CABG and post cardiac injury both can produce a pleural effusion. Then Ehlers syndrome, drugs will produce a pleural effusion with predominant eosinophils. Nitrofurantoin, dantrolene, dasatinib, methotrexate, bromocriptine, amiodarone, procarbazine. These are all the causes. I repeat, dasatinib, dantrolene sodium, bromocriptine, methotrexate, amiodarone, procarbazine with the eosinophils in the pleural fluid. Then as I told, the hemothorax and chylothorax again can produce an exudative pleural effusion. Iatrogenic injury, radiation, organ transplantations, all these can produce an exudative pleural effusion. Now some of the salient points, important points in pleural effusion. If the pleural fluid contains amylase, you have to think a pancreatic disease, esophageal rupture and malignancy. Especially malignancy and esophageal rupture will have a salivary amylase, whereas the pancreatic disease will have a pancreatic amylase. The spine surgery can produce a subarachnoid to pleural fistula producing a pleural effusion, which is a transudative. If pleural fluid IgM, IgG, IgA is more than serum IgG, IgA, IgM, it is highly suggestive of malignancy. Pleural fluid small ADA, if it is elevated, that is suggestive of a lymphoma. So pleural fluid IgG, IgA, IgM, if it is elevated than the serum, it is suggestive of a lymphoma. Some important points in the radiology is, which I will discuss again when I put the X-ray. Phantom tumor or a vanishing duct tumor. In a heart failure, the fluid can accumulate in between the fissures, which will respond to diuretics. This is known as a phantom tumor or a vanishing tumor. And one more thing is subpulmonic pleural effusion. Very important again. Subpulmonic pleural effusion, it doesn't obliterate the costophrenic angle. But just there will be elevation of the diaphragm. 1000 ml can collect under the parenchyma above the diaphragm. That is known as a subpulmonic effusion without obliterating the angle. Subpulmonic effusion. Then, to obliterate the angle, you need a minimum 300 ml of fluid. To shift the mediastinum, you need 1500 ml. Some of the very important points, students, which the examiners will ask. Then other points, what are the cause of pleural effusion in HIV? Kaposi sarcoma, lymphoma, cryptococcosis, tuberculosis, parapneumonic effusions. These are some of the cause of pleural effusion in HIV. I'll repeat, Kaposi sarcoma, lymphoma, parapneumonic effusion, tuberculosis, cryptococcus can produce a pleural effusion in HIV patients. Now, what are the cause of right-sided pleural effusion? Right-sided pleural effusion can be produced by the three already cardinal transudative effusion which I told: heart, liver and renal problems. Right-sided effusion. Subdiaphragmatic abscess on the right side can produce the right-sided pleural effusion. A Meek syndrome, ovarian hyperstimulation syndrome will produce a right-sided pleural effusion. And if a thoracic duct is ruptured below D5 level, produces a right-sided pleural effusion. What are the cause of left-sided pleural effusion? Esophageal rupture, pancreatic disease, subdiaphragmatic abscess on the left side will produce the left-sided pleural effusion. A pericardial disease will produce a left-sided pleural effusion. What are the cause of bilateral pleural effusion? Bilateral pleural effusion with cardiomegaly, without cardiomegaly. Bilateral pleural effusion with cardiomegaly is heart failure. Without cardiomegaly, pulmonary infarction, hypoalbuminemia, and malignancy. So bilateral effusion with cardiomegaly, without cardiomegaly. With cardiomegaly, heart failure. Without cardiomegaly, pulmonary infarction, hypoalbuminemia, and malignancy. These are some of the causes of some of the important points in the pleural effusion. So this is a detailed discussion of pleural effusion. Lucky to have a case with bilateral pleural effusion with no mediastinal shift. Okay, and X-ray already I had shown. Okay, so we can go through, and whatever I discussed, it is from the Harrison about the pleural effusion and from the clinical books. You can go through that. A nice case to have. It is for both undergraduates and postgraduate students.